Hi everybody, my name is Taylor Green. I'm one of the audiologists here at Audiology Associates.
My name is Rhys Barber. I'm the other audiologist here at Audiology Associates. So this first, but you have 3 patients in this video. Make sure you stay tuned for the last one. Really interesting case, the last one. But this first patient's mine. So you can see just very thick, almost clay type earwax, this one.
Bit of a pain.
Not the easiest of ones to get out, is it really, with microsuction? It just tends to block the tube a lot.
Yeah.
So the St. Bart's hook's been dusted off. It's out. It's coming into play on this one. I'm trying to create a little bit of a gap at the top because we've got this very thick, sticky wax at the front, but it's solid in the centre.
I was going to say, you're quite lucky you've got a gap, to be fair.
Yeah. It was a pretty chunky old plug, this one.
I mean, if that was completely blocked up, that would be more of a Jobson horn straight.
Oh, definitely.
Straight away. Yeah. You wouldn't be able to get the St. Bart's hook in. Oh, sorry, I'm losing my voice already.
We just started, man.
We just started.
Yeah, it would have been difficult to get, because obviously you rely on a lot of these curettage tools, relies on us getting behind the plug to be able to pull it forward.
Yeah.
And certainly with that St. Bart's hook there, we were really lucky we had that little bit of a gap. And the fact it was a little bit more solid, so you could dig into the centre and pull it forwards, then get behind it.
Oh,
nice and clear though. That's
all in one go.
I know.
Like to see.
It's always nice when it comes out like that. It's perfect. Similar, you can see a similar story on this side. I don't know if there's enough of a gap there to get the to get one of the tools through.
Pop some oil in straight away with the looks of it.
Yeah, that is solid though. This patient, basically what they'd done, they had blockages in both sides. That's exactly what you were talking about going with the Jobson horn there. They'd oiled one side but didn't oil the other because they felt that basically they didn't want to feel blocked up by putting the oil in both sides at the same time. So I've just popped the Jobson horn in here, just trying to create a gap. Going to use the St. Bart's, but you can see it's breaking, it's crumbly.
We've had it quite a bit recently where that's happened, where one ear may be completely blocked up and a particular patient would be really struggling with their hearing on that side. But then we take a look in the other side that they're having no problems with, and that's also fully blocked.
Yeah, that's right.
Yeah, I mean, it could be for a couple of reasons. I mean, a lot of the time we tend to see the wax right up against the eardrum on the one side, but not that far on the other.
Yeah.
But usually with the harder wax, again, the sound will generally tend to travel through a more solid plug rather than it wet and sticky.
Yeah.
So
I had somebody in all the tools are coming out in this one. I had somebody in the comment section yesterday. We were talking about the fact that sometimes patients come through and they're not really experiencing any issues as far as their hearing's concerned. And somebody made a really valid point. So, well, why are they in your clinic then? Why have they come along if they're not really having any issues? It's more to do with sensation. Sometimes patients will have a sensation there's something in there, or be feeling a little bit blocked up in the morning, and it kind of improves throughout the day, or just when they get some water in there, they notice they're blocking. So that's the sort of reason that patients would come through for these kind of things. This is solid. This block is absolutely solid. It does not want to come out of here.
You can just imagine the back of it's like holding on to it.
Yes. Gripping, clawing down the canal. It doesn't want to come away. I think it's moving a little bit. I'm trying to scoop round to the side here. It's just not really kind of, it's so solid. It's just breaking away. It's just crumbling. Not an easy one to get out. Oh, there we go. We've got a bit of movement now.
It's when it kind of gets stuck around that little corner, and it's very tricky to remove a manual tool then, because you've got to almost, like you said, kind of scoop it around.
It's very hard to do. And I think this one, in fairness, has formed on that sort of, we talk about those sort of first and second bends in the ear canal. So there's those sort of sweeping S shape to the ear canal. And I think it's formed on both of those bends. So that back bend is just gripping on. It just does not want to come away.
It's really narrow as well.
It's not the easiest. That cartilage is just starting to almost collapse over the front end of the ear canal entrance. They're just making it really, really narrow. Yeah. So the canal itself is open, but it's just that folded over section of the front that's a real difficult one to get behind.
Yeah, and that is generally something that can happen with age as well. So, somebody in their 30s or 40s, for example, might, their ear canal will just be, normal, what we would class as normal, and then as they get to their sort of 70s, the cartilage of the ear can sort of soften with age, and it just kind of starts closing in. Then it just almost like starts relaxing really in a way. And yeah, and you can see how easy it actually is to open up the ear canals, but it still makes it really tricky to do these types of wax removals, because we've only got 2 hands when we could do 3. Really.
Ideally, yeah, we could do like a third one. Should get one of those like Inspector Gadget things that comes over the top and lifts the ear up to you, just open it out. I mean, it looks, this is just fighting us every inch of the way down this ear canal at the moment. You know, and with this type of removal, I'd normally check in with the patient, you know, saying, are you okay? You're all right for us to carry on? You know, because it's not. Oh, there we go.
Oh, there we are. Yep.
There we are. So it's not always an easy one to remove. So you will find there'll be, you know, it'll irritate the ear canal, and sometimes it can be a little bit uncomfortable if you're taking a big, like that thing's huge, big old dart plug out like that. Yeah, and that's exactly what you'd want to do. That's exactly what you're going to see. Really, it's all the blood vessels that come to the surface in there. It's irritated. Patient could use a bit of ear calm in there, just to make sure we didn't run a risk of any infection, maybe.
We got, what's that, 2.5 centimeters?
Bang on an inch, or just over, like a 1 1/1/16 of an inch.
To be precise.
To be very precise, there we are. So this is your patient, this one?
Yeah, so this is mine. As you can see, that little white, sort of, well, it looks white on the camera because it's very bright, sorry. Right. That's actually the eardrum. So this wax is very, very, very deep in here. Very dry as well. This patient has been using some oil before coming in, and I'm kind of glad they did, to be fair.
Yeah, that is solidly down there, isn't it?
This would have been very difficult without it. And it's still very dry, even though they have used some oil. So this, I think, I think that's the fine end? I can't really
I think it is, yeah, looking at that.
More than likely going to be the fine end. Yeah, it's definitely the fine end. So we're just working really, really slow on this, because even though obviously the eardrum has got some flexibility to it, it's still uncomfortable for the patient on some occasions, especially the area that we're working on now, because that's pretty much where the bone is.
Yeah.
So the malleus will be sort of, you know, touching up against the eardrum, and we don't want to irritate the ossicular chain, the bones in the ear. It may cause a temporary change in hearing, which we don't really want to do.
It's going very well, though.
A lot more than what I was expecting, to be honest.
It's quite a bit jammed down in there, isn't it? You wouldn't expect wax to form this deep, so this has been pushed down there, isn't it? Really,
something has pushed it down.
I wonder what. Yes, patients be usually, if it's this deep in the ear canal, it is really kind of, you know, it's been pushed down there with cotton bud, something, Q-tips have gone down in there.
I've had an influx of those silicone, like spiral.
Oh yeah, I've seen quite a few of those coming through recently.
Yeah, don't look it up.
Yeah.
Don't use anything yourself, basically. No. Just get it looked at. Get a professional to look at it for you.
Speaking of that, Taylor, if you do have any problems with your ears or your wax, look how seamless that was. You can always check out a link in the bio to our website. Come and see myself on the lovely Mr. Taylor Green, and we'll get that sorted out for you. And if you do enjoy the videos, don't forget to like, heart, share, follow, and subscribe for us. That would be fantastic.
Absolutely nailed that.
Look at that, like a greased weasel, that was, isn't it? Right, so it's coming away nicely there, isn't it? Wow, it's really, really deep.
I hate these little bits, because even though we're kind of, you can see we're almost kind of touching the ear canal there, and that's just purely bone. There's a layer of skin on bone there, which is very, very sensitive.
You're right in that anterior recess there as well.
Yeah, but we did get lucky. You can see that's just kind of jumped up at the suction there, which is what I was hoping for.
Yeah. It always surprised me actually how much hides down in those recesses, you know, whether it be your anterior or posterior recess, but this one is all down that anterior recess, and you could really see there was quite a bit down in there.
And it only looked like a little tiny bit on the corner, but yeah, all kind of bunched in there. But yeah, there we are. Eardrum is looking understandably a little bit. I mean, it looks fine. There's no problems at all with the eardrum, but I think where that wax has been pressing up against it, just needs to relax a little bit.
There's a lot of skin down in there as well. Look at that. You've got, what's that, 2.5 centimetres again?
Yeah, same again, 2.5 inch.
It's always difficult when you're pulling out that recess, because you've always got that little bit of a lip, and you just want to just draw it very slowly and gently out, because you don't want to shear it off, because it'll be a nightmare to get down in there. So this is my patient. Really interesting case, this one. Now, we are going to pop a couple of different words up on the screen for this one, just because because we are going to throw a couple of different terms in there for this one as well.
And I still struggle to say it.
So yeah, we've been practicing saying this word all morning because neither we both of us keep tripping up over it all the time. But basically what you've got is a very kind of soft wax here. Patient has been having issues with their ears for a little while, especially following they came back from a flight last year and really struggled to get that sensation like they need to pop their ears. They really couldn't pop their ears properly, which is an indication of a bit of what they call eustachian tube dysfunction, which is bit where the eustachian tube is a little tube that connects from your middle ear space to your nasopharynx. So just behind your nose, we imagine you've got the soft tissues back there, it connects to there. And that's what we use when we pop our ears. That's what equalizes the pressure. That's where the pop comes from, is the sudden airflow through that tube. So they had a little bit of difficulty, but the eustachian tube dysfunction means that that tube is just not working very well. Could just be a little bit kinked, could be slightly squished in one spot. Lots of people who suffer with it have difficulty with planes and things.
Yeah, we do have not a lot of people, but we get occasional people coming in saying, "Oh, I'm getting lots of problems. I'm hearing a lot of popping and crackling."
Yeah.
I mean, that can be normal.
Yes.
Because that is the eustachian tube doing its job.
Yep.
It opens and closes. Releases some of the pressure that might build up in that ear. I mean, it can be as simple as driving over a steep hill.
Yeah.
A road going up a mountain, for example. It's any change in altitude can cause that kind of pressure to build up, and as it releases, that's where you hear those pops and crackles then. But it can also happen when you go diving as well. So when you go underwater, that's that pressure again building up.
So we get into these deeper, softer plugs coming away now. So the patient had been experiencing a few hearing issues, and understandably so, we got this soft plug wrapped in a bit of skin. So that's what was going on here. It's a little bit misty in here just because the patient's been using some olive oil. It's coated those little stereocilia right at the entrance to the canal. So as you're pushing the endoscope in, it's just coating the endoscope all the time, which is just giving this sort of slight blurring effect. But make sure you take a look at the eardrum. Now, we have slowed everything down so you can see the eardrum in a second, because there's a lot to kind of point out on here. Now, you will see it doesn't look normal, and we'll explain why that is as we're going along on this one now. So just taking this last little bit of skin away. There we go. Out that comes very slowly. There you go. So out that comes. We've got a little bit more skin. Now we can just start to see the eardrum beyond. We'll have a good old look at that now in a second, but you'll be able to spot straight away why that doesn't look normal. Okay, so we can see this section at the top here. Okay, now this is a very, very retracted. This is the pars flaccida because it's above the malleus here. And what you can see here, you can actually see the ossicles. So we can see the malleus, which is coming through the eardrum. That's the incus there, I'm just pointing out. And you can actually see the stapes further in as well. So this is a very, very severe retraction pocket. It's so retracted, it's actually stuck to the rear wall of the middle ear space there. So this is what we call a very severe retraction pocket. You keep an eye on this. You don't really want to see any debris in there. You were saying earlier when you've got to be really careful with it, just in case with...
Yeah, we'll more than likely... Oh, excuse me, guys, sorry again. We'll more than likely would have told the patient to come back after several months just to keep an eye on that retraction pocket, because you kind of risk when they're really, really severe and deep like that. Yeah. I'm losing my voice. You can risk cholesteatomas, which is... Yeah, it's not nice. It's not nice to see.
So you'd be looking for anything like keratin. So we talked about keratin before. It's the stuff your hair and nails are made out of. So where skin cells die off, they get filled with keratin, so they harden up. So what you can get in that retraction pocket, if you remember us telling you about how the skin migrates off the eardrum and forms the ear canal wall skin, if it gets into that pocket but can't get out, it'll harden up and form this keratin. And then you start to get all of that building in that space. And that's where you can get that cholesteatoma then, which is a collection of basically dead skin. But it can, in some cases, be quite nasty because it'll eat down either upwards, although it does tend to sort of hit this hardened portion of the bone and then we'll move around in the middle ear space. But it can also affect the ossicles themselves, and if it's left unchecked, it can be a real problem. More common with patients who have recurrent infections as well, isn't that kind of thing? So very simple wax removal, this one as well, taking this out as well. You're going to take a good look at the eardrum on this side as well. We think there's a possibility we've got something slightly different going on this side. So we just start to see the eardrum there. We're going to point out we've still got the retraction pocket in the pars flaccida. That's the retraction pocket there. But take a look at here. We've got another retraction pocket there in the pars tensor. Now, if you get you can get retraction pockets in the pars tensor. but you are more likely to get a condition called atelactasis.
And that's the
word we've been
isn't it?
struggling with all day.
Atelactasis.
Atelactasis is basically when the eardrum or the pars tensa, you get that sort of, the eardrum is almost, if you think about it, collapsed. So in the eardrum, you've got the pars tensa section, you have 3 different layers in there. So you've got your epithelial layer, you've got your radial, fibrous sort of layer in the middle, and you've also got the mucosal layer, which forms the wall of the middle ear space, which is producing all this mucus. Now what can happen sometimes, if you get eustachian tube dysfunction, you can't equalize the pressure very well, you've got air in that middle ear space all the time, but that sometimes gets absorbed into the sort of cells and tissues around that middle ear space. So as it gets absorbed in, the pressure keeps dropping and it keeps pulling the eardrum in. Now, if it gets pulled in so far, what happens is that radial section in the center there just starts to degrade. So you end up with a very floppy piece of skin. So a bit like cling film. If you warm up cling film, it becomes really, really stretchy and sticky, and you drop it over something, it drapes over it. That's exactly what happens with atelactasis. You start to get it draping over the middle ear, sort of the ossicles and bits of the middle ear space as well, and it's really difficult to treat.
And they can almost adhere and glue to the middle ear wall cavity, which more than likely it's an operation more than likely that they may need. And depends on the grade of it really. I mean, if the eardrum is still mobile, then
you could look at maybe like a grommet, something like that, but that's down to an ENT's call.
That's not our job.
It's not our job, thank God. But that's, that would be down to your ENT consultant looking at whether you could be able to aerate it. You can do lots of things. If you do stuff for eustachian tube dysfunction, things just as simple as blowing balloons up, doing that a couple of times a day, that will help to just get a bit of air back in behind that eardrum and in the middle ear space as well. But a really interesting one for you guys to watch. So guys, thank you so much for watching our video today. And as always, take care of yourselves.
Take care of your ears.
And take care of one another, and myself and the lovely Mr. Taylor Green. We'll see you for the next video. Bye everyone.
Bye.